So the topic is atrial fibrillation, which NOAC and when. So atrial fibrillation, for the benefit of the students, it's a commonest arrhythmia in the world today. It is not restricted to any particular part of the country. It is global bird, and now we are seeing every part of the world is suffering from atrial fibrillation, which is a chaotic activity of the atria, which beats at the rate of 400 to 600 beats per minute. Practically, it is not pumping the blood. So the patient loses the atrial kick, which is contributes from anywhere between 15 to 25% to the given individual to the cardiac output. When they develop atrial fibrillation, because of that, their cardiac output comes down. That can lead to various problems. One of the problems which you face is a stroke. So if ESA is predicted that, at the age of 55, 1 out of 3 individuals have the lifetime risk of developing atrial fibrillation. As the age increases, you can see the graph, as the age increases, you can see more and more. At the age of 60, the risk of 10% has become double at 20% at the age of 20, as age advances. The reason being is multiple comorbidities, as apart from the aging and male sex and ethnicity and genetics, apart from that, increasing incidence and prevalence of non-communicable diseases, which you can see here: hypertension, diabetic, dyslipidemia, obesity, OSA, alcohol, smoking, vascular diseases. Everything contributes to the development of atrial fibrillation. So many factors plays a role. That's why we are burdened with this global burden of this atrial fibrillation, which puts humongous pressure to the economy. So there are two ways of patient presents to us. Not everyone come to you with this documented AF or symptoms. One subset of patients who have subclinical AF or, so then they implanted any devices like pacemaker, ICD, CRTD. We find out that when they do not even have any symptoms, but the documented continuous recording of the device shows that they are going for in and out of atrial fibrillation. Sometimes, the patient come to us with the clinical symptoms. That varies from clinically stable symptoms like palpitation, breathlessness, giddiness, or some sort of symptoms, or they reach sometime ER with acute pulmonary edema or cardiogenic shock or the syncope or hemodynamically unstable status. So the wide spectrum of presentation is there's a problem with atrial fibrillation. Predominantly at subclinical or asymptomatic, or significant number of patients with the symptomatic. Some subset of patients come to us with the hemodynamically unstable status. Irrespective of the thing, is no longer considered as a benign disease. It is, Framingham data clearly showed that it increased the mortality by 2 times. Major problem with this atrial fibrillation is stroke. 1 out of 4 to 5 strokes, that is nearly 20 to 25% of the strokes, are related to atrial fibrillation, which is embolic phenomena. So the patient, whenever they come to the stroke, they go to the neurologist, but they never detected to have atrial fibrillation, because at that point in time, they may not have the atrial fibrillation. It may be coming and going. It's a paroxysmal in nature. It can cause a stroke. So whether it is paroxysmal or persistent, the risks remain the same. As persistent, it becomes the more incidence of stroke and hospitalization. Apart from that, they also suffer heart failure due to uncontrolled heart rate, lack of atrial kick. They go into cardiac cardiomyopathies, and they can get into heart failure. So, and then most important thing is increased incidence of stroke and leading to subclinical strokes and dementia. As they followed the patient more and more, they found there are a lot of depression and dementias has been noted in this patient, and then hospitalization for heart failure is also increasing. So when they characterize the AF, the most important thing is stroke management. How is the risk of developing stroke in this patient? What is the symptom severity? And then what is the burden? How is the paroxysmal or persistent? Or what is the time he spends on atrial fibrillation? And then what is the substrate? Are you suffering from valvular heart disease or atrial myopathy? What is the substrate which is causing this atrial fibrillation? All those things to be analyzed to put a plan for that particular patient. So the guideline clearly says that when you want to manage the atrial fibrillation, the first and foremost comes for stroke prevention. Optimized stroke prevention is the most important thing. Then comes to symptom control with the rate control or rhythm control. Then comorbidity management, which I put it, hypertension, diabetes, all those things to be managed, obesity, all those things to be managed. But in terms of managing the atrial fibrillation, it is no longer restricted to only cardiologist or the physician. You can see the people are involved in this chart. There are various people are at a different point of time, including the home caretakers, AF nurse, and pharmacist, and so many specialists involved. That's where we are facing the problem. Cardiologist starts the medication, the patient goes somewhere and gets medication getting stopped. So it's very important to everyone in this thing will be aware of that, what is the importance of stroke prevention in atrial fibrillation. So ABC guidelines clearly says that avoid stroke is the most important thing. Even the developed countries, 8 randomized trial, when they analyzed it, only 21% of the patients were treated appropriately as per the guidelines. When they are treated appropriately with the stroke prevention and comorbidity management, the ischemic stroke comes down, bleeding comes down, mortality benefits, they get it. But even if it's developed countries, only 20% of the patients have been treated appropriately as per the guideline. So when you come to the stroke identification, so CHATSA score is the commonest score. Most of you are aware of that. Is a CHATSA score. Based on the scoring, we have to risk stratify the patient. Is they developing risk of stroke or not? Most important thing is congestive heart failure, hypertension, age more than 75, diabetes, and stroke, previous stroke, all those things given weightage, and vascular disease, age 65 to 74, and sex category given 1 point each. As per the score, I will come to later. But the problem with the CHATSA score is, so there is a fin to globally, it is widely applicable. Is it okay to applicable globally? So the people who tried in Asian population, that they found to have little more stroke prevalence and more higher incidence of stroke compared to the Western population. The Chinese come out with some score, chest score, and where they found 8 lakhs patients been analyzed and prospectively applied in Korean population. The difference between the score is they have included their thyroid disease, hyperthyroidism, which was not there in the score, and also they put COPD, which is the other marker for the increased risk of stroke. And Taiwan people has come out with the other scoring system. The age more than 50 itself, they included weightage. And then they include alcoholism, ESRD, all those things given weightage for the score risk prediction. As you can see, that score is less than 3 is low risk, and 4 to 9 is medium risk, and anything more than 10 is a high risk patient. So we have to individualize the patient. The scoring system is a rough guideline. We have to individualize the risk, and with that particular patient, what is the risk of that getting a stroke, and how are you going to prevent it. Once you are going to start some blood thinners, the most important thing is simultaneously work out for what is the risk of, when I put him on a blood thinner, what is the risk of developing the bleeding risk. That's what we see, that bleeding risk is, so we have to work out that any scoring of 3 or more is increase the risk of bleeding risk. So as per the scoring system, CHATSA score, which is widely popular and widely used, it is a score of 1 or more in male and 2 or more in female is indication for NOAC agents. And then these drugs should not be used for the mechanical valves as well as mitral stenosis or moderate to severe mitral stenosis. The available drugs are apixaban, dabigatran, edoxaban, rivaroxaban. Edoxaban is not available in India, so we'll talk about apixaban, dabigatran, and rivaroxaban. The most important things every physician should aware of the dosage. Here only we are getting into a problem. Under dosage or unapproved dosage usage is the problem for the patient. They start the medication, but they don't give the appropriate dose. The dabigatran is 150 milligram twice daily. Lower dosage is 110 milligram. Rivaroxaban 20 milligram once a day. Apixaban 5 milligram twice a day. Rivaroxaban and apixaban reduced dosage can be given in a subset of patients where the GFR is less than 49. And then for apixaban, it's 2.5 milligram to age more than 80 years or below body weight of 60 kilogram or creatinine more than 5. So this is what the dosage. And a few take-home points, very important points. The common thing is when the NOACs to be given in a PCA patient, in an elective PCA, if you do it, 1 week triple therapy is sufficient. After that, 6 months of dual therapy, then monotherapy of NOAC alone enough. In the patient of ACS with the PCI, triple therapy for 1 week and 6 months of dual therapy, and after that, long-term only NOAC agent alone is sufficient. So nowadays, we are no longer using vitamin K antagonist. We are using only NOAC for all stroke preventions. And somebody developed TAA, you can start very next day. And the guidelines, American guidelines says that the period is 4 to 14 days is the window. You can talk to the neurologist, appropriate period based on the imaging, brain imaging. You can choose to start the medications. Any intracranial hemorrhage, you need to wait for at least 2 weeks. And the patient who developed recurrent stroke in spite of NOAC agent or not already NOAC agent, appendage occlusion should be considered. And the patient coming to the stroke on NOAC, thrombolysis cannot be done for 48 hours unless you have the antidote which is available for dabigatran in our country, idraximab. You can give the antidote and then you can give thrombolytic therapy. In valvular heart disease, as I said, moderate to severe mitral stenosis, this is contraindicated. Mechanical valve, this is contraindicated. Other drugs, you can use it. And then for TAVI patients, you can give only PCA agent. For in Asian population, NOAC is the preferred, and then these are the drugs, dabigatran, apixaban is more commonly preferred in this patient. Which one? Asian population not showed any benefit one over the other. Even across the globe, some drugs are causing more bleeding, more GI bleed, but in Asian population, we have not seen anything. One thing is stand out to be prominent is dabigatran 150 milligram twice daily is dominantly reducing the ischemic stroke. In terms of side effects, all are equal, and we tend to more prefer with apixaban or dabigatran compared to in elderly people compared to rivaroxaban, because rivaroxaban is more neutral or slightly tendency to for more bleeding. I conclude, the option is available for the patient. The most important thing is, another thing is, the patient is not tolerating NOAC agent. They have been given antiplatelet. Antiplatelet drugs are contraindicated. This is no longer going to prevent the stroke. When the patient is not tolerating the recommended dose of NOAC agent, they should go for appendage occlusion. That's what we have done for this particular patient. She was not tolerating it. We have done it. Simultaneously, we have the therapy for AF ablation with the cryoballoon, so that maintaining sinusism itself reduces the risk of stroke dramatically. Even though it is not recommended to prevent the stroke, it reduces it dramatically. And then on the top of that, the same patient, if you occlude the appendage, then she can be only on aspirin tablet, which is more than sufficient. So this, which I conclude, the most important thing is when you put the atrial fibrillation clinic, which we run, and patient will be screened for AF in a stroke patient, an appropriate strategy to be followed. If they are not tolerating it, we should go for appendage occlusion, and the given patient not tolerating medication, which has the efficacy of 40%, with invasive therapy like cryoballoon or ablation or AV nodal ablation, the success rate goes up to more than 80%. So in a given patient, AF will be a comprehensive management is required for the best outcome for that particular patient. Thank you very much.
Thank you, Lord, Dr. Karthigesan, and to please remain on stage, and the session is open for Q&A.
Pulmonary vein, sir, pulmonary vein. No, it will not go back, I don't think. So it's in the pulmonary vein. It's in the left atrium and pulmonary vein. It's atrial fibrillation pathogenesis is ectopics coming from the pulmonary vein. So we ablate around the pulmonary vein. It's a cryoballoon is a fibrillation. It's a pulmonary vein isolation. Nothing to do with the pulmonary artery. Inferior vena cava, transeptal approach, get into the LA and do it. How long? Ablation is for each vein 4 minutes.
How long you can keep it, unless it causes perforation? Is it possible?
No. These are all safe therapies. No, there is no perforation and all those things.
Is it thermotherapy or only dilator therapy? Which way you have to consider?
I think this is detailed questions which can be shared on one-on-one. I'm so sorry to interrupt. We need other questions to be answered as well, and we are running short of time. Thank you so much, sir, for your very interesting questions. You'll be available for taking. Yes, ma'am. Just a moment. The mic is coming to you.
Just from Pondicherry, but doing diabetology for the past 15 years and done a little bit of cardiology also with Dr. Chennai. This question, some 32 years back, I lost my mother who had tight mitral stenosis following post-operative hernia repair. She went into pulmonary embolism, but it was not diagnosed. As you said, large number of people go in for stroke with atrial fibrillation. But that time, we did not have much anticoagulants except for Dindivan. So there was a dilemma in starting heparin therapy, even with the cardiologist, I don't want to mention. But then it took 7 days before she went into pulmonary embolism. But before that 7 days, she was presenting with just lip smacking and memory loss in between. And it was, at that time, I was a junior resident in cardiothoracic, and we found only 7 cases presenting like that, and it was told as temporal lobe seizure presentation. Would like to hear your experience, sir. How many people present as temporal lobe seizures before you take them for any other therapy?
No, the talk is on NOACs and atrial fibrillation. Atrial fibrillation, mainly these drugs are widely used nowadays. We are no longer using vitamin K antagonist for non-valvular atrial fibrillation. In valvular atrial fibrillation, mitral stenosis, which is we don't use it, and mechanical valve, we don't use it. All other conditions, when the patient presented to us with atrial fibrillation based on the Chatsworth score, we start them on NOAC agents. But the embolic manifestations are different. The post-embolic sequelae is seizure is one of the sequelae of the stroke. When the patient silent or symptomatic stroke, when they follow up, they manifest like a different kind of stroke. So different kind of seizures. So temporal lobe epilepsy could be one such variety. But so the stroke prevention and identifying this atrial fibrillation and put them on anticoagulation is the main strategy in this patient. But luckily, as you said, in those days nothing was available. Now,
case, sir.
yeah, postoperatively is very important to once you do something for the mitral mechanical valve, we always put them on anticoagulation. So that is very, very important. And anticoagulation, it's a cornerstone in stroke prevention. And then once you develop stroke-related consequences are what you are mentioning, which can happen to any patient.
Morning, sir. Sir, in few patients, we cannot able to stop a single antiplatelet therapy. If you want to combine NOAC with AF dose, what is your preference? What is the suggested dose
So
of?
that is very important. So when don't want to, so that's why I put the PCA plus NOAC agent, I put it. Now the guidelines are clearing that there is no such situation where you cannot stop antiplatelet drugs. You can stretch up to 1 year, 6 months to 1 year. After that, there is no indication to continue the antiplatelet drugs. The patient needs NOAC alone is sufficient. No need to continue that. Well, that's what we see most of the CABG or PTCA patients continue to take antiplatelet. But you can stop the antiplatelet, depends on the complexity of the PCA, 6 months or 1 year, so whatever. After 1 year, there is no indication to continue antiplatelet drugs. They can be on NOAC. But still, some reason you want to continue that, reduce the dose. Apexaban 2.5 milligram twice daily or rivaroxaban 15 milligram is sufficient when you want to add with one antiplatelet drugs.